on the announcement on the webinar, this is the X-ray chest or an X-ray chest, which is very similar to this one. So I'll tell you a little story of this X-ray chest. This is an X-ray chest of an 18-year-old who came for a physical examination. And this was an incidental finding. So an X-ray chest with dextrocardia and situs inversus, what I've learned is normally an incidental finding, and very few times they present with cardiovascular emergencies. Let's see why. I have no financial disclosure. And the layout of my presentation is very simple. I'm just going to discuss 3 or 4 emergent clinical presentations and what are the causes, cardiovascular causes of these presentations. I think it's asking me to show the taskbar. Okay. So now let's look at this. Recently, I've been using this 2 townhouses picture in the last 1 year, couple of times, because I find it very easy. It makes me understand pathophysiology.
Recording in progress.
So if you look, this is the right side of the, I'll just use, this is the right side of the heart, and the other is, of course, the left side of the heart. The rule is that liver will be on the right side and stomach will be on the left side. One townhouse and the other townhouse, they cannot travel from one place to this place. So if you look carefully, they do definitely look the same, but there are differences, and that is what our heart is like, that the right side and the left side have different functions, and they work in parallel, and they should not work in series. That means when you start going from first floor to the second floor to the top floor, that is okay, that is normal. But if one wants to come down, then that is not okay. So what are the clinical scenarios? The clinical scenarios are, first common is the cyanotic baby. The second will be a pink baby who may present with congestive heart failure. And the third scenario will be a mottled or Asian and gray baby who is having a cardiogenic shock. And all these 3 presentations can be preceded by extreme irritability. So in other words, irritability should never be ignored. Let's look at our first scenario, which is cyanosis. The age of presentation is normally the first 2 weeks of life. Pulmonary versus systemic circulation, it is the pulmonary circulation which is poor, and the category is that the right side of the blood is going to the left side, or there is mixing of the oxygenated and deoxygenated blood. And normally on physical examination, the oxygen saturation is less than 80 degrees. 80%. So let's look at our first case. This is a late preterm with cyanosis and respiratory distress. If you look at the X-ray, of course, most of you will recognize has an upturned apex, giving the heart a boot-shaped heart. And the lungs look a little more black than normal. The baby underwent echo, and beautiful report came out: pulmonary stenosis, ventricular septal defect with overriding of aorta and right ventricular hypertrophy. So, my first question to my audience is there a need for any further imaging after this report? The options are either yes or no. So, the chances are you're going to be 50% correct. It's going very close. So, 52% of audience thinks there is a need for further imaging. Let's see. Okay, we did a CT scan which shows beautifully the ventricular septal defect with overriding of aorta and of course the pulmonary artery stenosis. So this is overriding, this is septal defect, this is pulmonary artery stenosis with right ventricular hypertrophy. So this the our worthy cardiologists already know what further, how further can we help. The same case now, if you look, their expectation from us is that we would look at the interventricular septum very nicely and see if there are any additional VSTs. Is there a PDA which is patent? Then we have to tell them the length and what is the caliber of the PDA and what exactly is its relationship to the neck vessels and to the right or left main bronchus, because in pathology of fellow they may want to keep stent the PDA, and for stenting they will need all this information. What else they expect us to tell them is the origin of the coronary arteries. Normally, our patients, these little babies, have heart rates at 120 or more than 100 most of the time. But if you're using prospective ECG gating, you will be able to tell them the origin of the coronary arteries, because anomalous right coronary artery, we have to tell them, because that will be very important for them in management. And of course, any additional findings like this, the anomalous right subclavian artery. And then you can make very beautiful 3D images and show them, which will be very helpful to them. Let's look at our second case. This is a teenager who presented to us for the first time. On arrival, it was known that the teenager has tetralogy of fellow, and so the question to us was that what would you want to do, because they wanted us to tell them, is it because of infection he's having hemoptysis, or it is because of vascular anomaly. Can we have the second question? Okay. 59% vascular anomaly. So 59% of our audience thinks it's a vascular anomaly. And what is the most common vascular anomaly in this patient is Sharia. It's not changing again. We'll always have some kind of little glitch.
What is the problem, Dr. Naila?
The slide is not changing.
Okay. You can stop sharing and then start sharing again.
Yeah, I'll do that on the
And
spot.
yeah, and the poll, please. Share the results and then मैं share कर रही हूँ. Then now. So this is the result. Should I stop sharing?
Yeah. So Kiran is saying, okay,
Stop share and then start sharing. This will happen sometimes in the poll.
okay, okay,
Now we can see your slide.
okay. No, we'll have to stop
Your screen.
sharing.
Now share again. Now we can see. Now is the slide is moving? No, we can't see.
No, I think we'll have to stop sharing and then. Yeah, I'm sorry. So the we'll be back to the teenager presenting with hemoptysis, and you can see again the boot-shaped heart, the black lung fields, a VSD, hyperplastic pulmonary arteries, and you can imagine now this person has lived without any surgical treatment up till now, is a teenager, bit tough. So what has happened? What has happened is he has developed multiple aortopulmonary collaterals, and they are known as hypertensive collaterals. If they are more than 3 millimeter in size, they are tortuous, and they have abrupt tapering at the periphery. They develop aneurysms and may present with pulmonary hemorrhage. So, as a radiologist, when you are reporting these cases, you have to tell them. So, normally, most of the time, it is better to tell the largest one, at least supplying the right and the left lung. Another case, known case of TOF, of course, with cyanosis, but additionally had difficulty in breathing, and on echocardiography, they were not able to understand whether the aorta is right sided or left sided. They asked us to do a CT scan and to tell us if there is a vascular ring. So, if the question is there and you have had a good discussion and you are able to control your patient's respiration and everything, then the best thing is beautiful CT results you get. So, this was a double aortic arch, and in double aortic arch, you have to tell them which side of the arch is dominant, because the non dominant side they resect. In 10% of the cases, like in our case, it can be symmetrical and of equal size. Another patient with cyanosis, known TOF, had repeated left lower lobe collapse, and they wanted to know the cause of it. And one of the very rare cases, I think I've only reported so far 2 or 3 cases, pulmonary sling, the left pulmonary artery coming out of the right, crossing the midline between the esophagus and the trachea, and then supplying the left lung. And the concomitant presence of ligamentum arteriosus results in complete vascular ring that encircles the trachea but spares the esophagus. And it is one of those anomalies where the tracheal stenosis is quite long, and there are two types, and additional bronchi can supply both lungs. So these patients have a lot of symptoms. So the role of radiologists are numerous, but few which, when we are reporting our cases of tetralogy of fellow, we should remember to carefully address and write about additional VSTs, the length, the anatomy, the caliber of the PDA, origin and course of coronary arteries, the MAPCA's description, any additional finding, and of course, then these patients are being managed very well, and the post-op findings, so we are getting more and more of them. Cyanosis apparent within hours of birth. Now, just look at the heart again on the plain x ray. The student's favorite, a more typical boot shaped heart. However, the lungs are not that black. And when the cyanosis is apparent within hours of birth, if not known antenatally, think of DTGA, that is transposition of great arteries. And in this, you can see the pulmonary arteries overriding the ventricular septal defect, just like in TOF aorta was doing it. And this patient also had an anomalous origin of the right subclavian artery. And the patient started having symptoms as soon as the PDA started closing, because if there is no shunt, this is not compatible with life. So if there is no shunt, they do it on the bedside, atrial septostomy. So again, a question to the audience. Mom says baby turns blue on crying. Is this tough? Well, 51% thinks it is not tough. Yes, I agree with you. This is not tough because let's look at this X-ray chest. Yes, you're right. The apex of the heart is upturned. The heart looks boot shaped. But then you also have to look at the lungs, and you can see there's significant pulmonary plethora. Our TOF patient has obstruction to the pulmonary vasculature, so their lungs are normally very black. So the lesson learned is every boot shaped heart is not tough. Boot shaped heart means right ventricular hypertrophy. Every patient who presents with cyanosis does not have TOF, may have other reasons like truncus arteriosus, like transposition of great arteries. And this was a case of truncus arteriosus. Let's look at our second clinical scenario. The baby is pink, presents with shortness of breath and pedal edema. And pulmonary versus systemic circulation, it is pulmonary congestion. Now the lungs are full, and age of presentation is between 1 to 6 months. Shunting is from left to right side, and there's pitting edema. There may be hepatomegaly and murmur. So if the left side of the heart is affected, it is the lungs which have more blood, but if the right side is affected, it is the liver which has more blood. So, heart failure in children can occur in a number of conditions. The commonest are arrhythmias and left to right shunts. Severe anemia can also produce pericardial effusion, hypertension, pulmonary hypertension, and cardiomyopathy. Let's look at our two children who presented to ED, two different patients with shortness of breath. On examination, one of the baby had a raised jugular venous pressure, hepatomegaly, and peripheral edema. So it is easy to guess that this may be the patient, because if you look, it is a case with pulmonary edema. There is definitely enlarged heart. Right, left atrium is also enlarged. Left ventricle is also enlarged. There's pulmonary plethora. There is ground glass haziness, and this is a known case of VST. While in this case, if you look, so I've put an arrow at the aortopulmonary window is quite full. So normally this is one of the differentiating features which you may or may not see in cases of PDA. But every time you see these patients, there will be lot of air in the lungs, and that is because their pulmonary arteries are big, they keep compressing on the bronchi, they may have upper respiratory tract infection that also presents with air trapping, or they may have pulmonary edema, which also causes one of the first signs is air trapping. This is another case, repeated chest infection, known VST, and they wanted to know if there is a tracheal stenosis or a vascular ring. We couldn't find a vascular ring, but if you look at the trachea, there is definitely narrowing. And just look at the left main bronchus, it is all narrow and compression. So patients with VSTs will keep on presenting with large PDA, will keep on presenting with multiple lung segment collapse and air trapping and respiratory distress. A 3-year baby girl presented to ED with increased work of breathing. Again, was a pink baby, was in congestive heart failure. If patient had to be intubated immediately in the ED, central line had to be passed. If you look at the X-ray chest, I always tell my residents, never say it cannot be commented on. Despite supine position, the heart is enlarged. Patient has signs of early pulmonary edema, and echo was done and severely reduced LV systolic function, and this is a case of cardiomyopathy. So now the question is very confusing clinical scenario. Patient has cyanosis, but also has signs of congestive heart failure, and this is in the early neonatal period. Looking at the X-ray chest, is there a panic alert? So the answer is most of the audience there is think it is yes or no. Yes. Yes, you're very right. Endotracheal tube tip is in the right main bronchus, which is resulting in collapse of the left lung. The patient definitely has decompensating heart. So if not known, this itself is a panic alert because the baby is developing pulmonary edema and the heart is decompensating. So, take home messages, although many lesions have distinctive appearance on chest x ray, like in just before exams, we are trying to learn what is boot shaped heart, what is egg on string appearance, what is snowman. Mistakes will be made if a radiological diagnosis is attempted without knowledge of basic clinical details. How your patient presented, that is important. This was what was happening to this patient, severe cyanosis soon after birth, presented with congestive heart failure. Why? Because patient had total anomalous pulmonary venous drainage, infracardiac type, draining into the portal vein, and which has developed an aneurysm. So signs of obstruction are present. That is why he has developed now pulmonary edema. The left side of the heart is hypoplastic, and these patients are known to have multiple episodes of pleural effusion and reticular thickening, and this is the worst kind of lymphangiectasia. The snowman is not present every time with TAPVR. It is the supracardiac type TAPVR, total anomalous pulmonary venous return, which will have this typical X-ray. This X-ray, of course, these two X-rays I've taken from the internet. Let's look at clinical scenario now. Neonate with severe cardiovascular collapse. The baby was in cardiogenic shock, has a gray mottled appearance, and when the X-ray test was done, you can look. The heart is enlarged again. It is decompensating. Early signs of pulmonary edema was developing, and when we did a CT scan, by virtue of very good contrast, this is your venous system, this is your heart, and look what is happening to the aorta. It is interrupted. The descending aorta is being formed by a large PDA coming from the pulmonary artery. So the patient also had transposition of great arteries, VST, interrupted aortic arch, and symptoms start with when PDA starts to close. This is our baby who presented to us with extreme irritability, 11 months girl, and it was known case of cardiomyopathy. So they wanted to know further about it because the cardiologist couldn't see where the left coronary artery is coming from. So we did a CT scan, and you can see this is pulmonary artery, this is aorta, this is left ventricle, and look from the pulmonary artery, the left coronary artery is coming out. This is known as Al-Kappa. And Al-Kappa itself is a very rare cause of dilated cardiomyopathies. These children are really have an emergency. God forbid they can die or can develop a huge infarct. So, if we just look at again a little bit about a cardiogenic shock, poor general status with marked hypotonia, decreased level of consciousness, bradycardia, immeasurable blood pressure. The three general categories which you immediately should think are cardiomyopathies, arrhythmias, and obstructive disorders. Either it is severe coarctation of aorta, or it is hypoplastic left heart, or interrupted arch. So, my take home message is every boot shaped heart is not tough. It means right ventricular hypertrophy. Every blue baby is not tough. Immediately when the babies present with severe cyanosis after birth, it is either DTGA or total anomalous pulmonary venous return without a shunt. Both are not compatible with life. ASD, VSD, PDA will keep on presenting to you with the air trapping with, and you really have to dig in the history to know why the air trapping is present. In circulatory collapse and neonatal period, think of obstructive disorders, interrupted arch, and coarctation. So I've put a quote from a very huge meta-analysis, and I keep it quite close to my heart. That is, clinical information improved integration accuracy, clinical relevance, and reporting confidence. These are my references. Thank you very much.
Thank you so much, Dr. Naila, for a wonderful discussion. I will now request Dr. Maria to please start her talk.
Bismillahirrahmanirrahim. Assalamu alaikum and a very good afternoon to all of you. So my screen is visible to everyone. Please confirm in the chat box. Am I audible?
Yes, ma'am, you're
Okay.
audible and the screen is visible.
Okay, thank you. Perfect. So after a mesmerizing and a very nice talk by Dr. Naila, my mentor, on a very interesting topic, that is cardiac pediatric emergencies, and so many complex cases with so many different practical tips. So let's delve into another uh, entity, that is the pediatric chest. And now this is a non-cardiogenic emergencies today we are going to cover. And before starting my talk, I just want to say a few words regarding the children, that children are not small adults, they are different. And why? Because they have so many different kind of tissue proportions, they have different heart and respiratory rates, and many of the people who are doing adult radiography or adult radiology, they find peds as a very difficult subject. So thing is that these are very different because of the fact their maturation, due to their maturation, their ongoing processes that are happening in their bodies, they have a different stages, like starting from neonate, then comes to the infant, then the toddler, preschool age, then adolescents. Are those so many changes that are occurring in their body, and those changes are being reflected on imaging in a very different things. So the profound knowledge of these stages is very important before starting the pediatric radiology. So that's why not only the disease patterns, but some of the variants are also present in the children. So that's why they are different. So learning objectives, as we are dealing with the pediatric chest emergencies today, and this is a very wide topic, and there is no way I can just within 30 minutes. So let's starting with a short visit to the pediatric chest emergencies, and starting with a few interesting clinical scenarios rather than didactic talk. So we are going through some important chest emergencies followed by a few pitfalls. And I will start my presentation with a very famous quote by Walter Lippmann, where all think alike, no one thinks very much. So let's start. So I have no financial disclosure, and I have taken few cases from internet for educational purpose. So this is my case one. So there is a child who is presented from OPD, and he's so unwell and presented with cough. And this is the X-ray we are being provided. So here are the options for you. So the findings on the chest are characteristics of, is it right upper or middle lobe consolidation? Or is it something that you remember initially, but now you forgot? Maybe some of you are thinking on the lines of mediastinal mass. You think this is a normal, or is it a lung mass? So let's see how our audience is thinking. So please focus on the capacity in the right upper lobe. So there are mixed answers. So majority thinks this is normal, and 43% of the audience thinks this is mediastinal mass, and only a 9% of people are thinking that this is right upper lobe consolidation. So all right, these are the great results. So majority is right. So I'm dealing with a very nice audience today. So absolutely, this is a normal case. So it's not changing again. Just a minute. Mhm. No, it's yes. All right. So this case was normal. So I'm very happy with the audience. So basically, what's going on? We are here dealing with a mass-like opacity that is seen sitting in the right upper lobe, and it is abutting with the right horizontal fissure. But if you are going to focus on this opacity, what is the consistency of this opacity? Here, if you compare this opacity with the right lobe of liver, so the liver is so much dense. Rather, this opacity is transparent. Here you see there are so many bronchovascular bundles are seen obscured, not obscured by the mass, and they are seen through via this steel. Moreover, if you are going to focus, there is a nicely demonstrated trachea, the carina, right and left main bronchus, but there is no compression at all. So this is a normal thymus that are you being expected in this age group. So beware of this entity. This is a normal variant, and you always find it in a normal child. Don't confuse it with the pathology. So here I'm showing you different case just for comparison. You see here, this is a normal thymus, the same case, and compared to that, this is just X-ray of another patient in which there is right lobe pneumonia. So if you compare this density, look at the both densities. This is the jet white density. Again, it's bounded by the right horizontal fissure, but we are not able to see anything via through this density because it's very opaque. And moreover, if you are going to focus this trachea, we are not going to trace it, but there is compression. So this is right upper lobe pneumonia compared to this normal thymus. So always remember, thymus is very fragile tissue. It is seen in a neonate in a very full-blown stage, and after 2 years of age, it is going to involute. So after that, it is going to involute and shrinks, and after 8 years, you are not able to see it on the chest radiograph, rather on the cross-sectional imaging. So let's see few more phases of the thymus, because this is a normal physiological variant. So you are going to expect to see in every child. So that's why the familiarity is very important. So this is a triangular thymus that is again abutting the right horizontal fissure. It's a very famous sign of the sale sign. So another sale sign, it's now on the left side. So because of the normal anatomy, because of the normal anatomic configuration of the aortic arch, most of the time you're getting this thymic tissue on the right, but sometime on left. So beware of that. And here is another X-ray in which there is thymus that is extending not only from above downward up to the right paraphrenic region, up to the diaphragm and in right pericardial margin. So basically, it can have many phases. It can appear at any time, sometime on the left side as well, and it mimics the pathology. So if you are knowing the normal appearance, so you get familiar with that, so it would be more easy for you not to misinterpret it as a pathology. So if still you are confused with the thymic tissue, you need to confirm it on ultrasound. Here, ultrasound is your friend. So on ultrasound, it is showing a very coarse, homogeneous ecotexture. Remember, it's a lymphoid tissue. It is consisting of the cortex, the medulla, and a very nicely demonstrated capsule. Here you see this is a TS view. So again, it is showing a very homogeneous ecotexture. So you can confirm it on ultrasound. So ultrasound is your friend over here. So again, here we are dealing with another case in which you see there are certain impressions being lying on the thymic tissue. So whenever you are getting these kind of impression, these are basically the impressions of the ribs. Because it's a weak tissue, so there are is impression with every respiration. So that's why if you are going to see such kind of impressions on the thymic tissue, then it is a short sign of the thymus rather than a pathology. So beware in your mind. So there is on this particular sagittal CT scan, again, there are impression on the lung tissue because of the ventral ribs. So take home message of this slide is that beware of the normal variants. So here we are having another child with distress. So what do you think is this normal thymus? So here, if you are going to focus, there is another opacity that is seen in the left heart border. So it is silhouetting the left heart border rather than it is seen through that, like the thymus as we saw in previous case. it is causing silhouettement of the left heart border. So this is not surely a thymus rather than a pathology. So if we are going to focus this further, there are multiple coarse calcifications. So this is a zoomed view. Again, you see there are multiple coarse calcifications seen in the background of this mass. So of course, this is an anterior-mediastinal mass. So we proceed this case with an ultrasound, and on ultrasound, you see there is a very complex looking mass having multiple kind of densities. Here, this is a fluid, soft tissue, some calcification, and dependent debris. So this is a short case of a anterior-mediastinal mass, that is teratoma, and that was being confused as a not to be confused with a normal variant, that is thymus. So sometime the variant can mimic a pathology and vice versa. So the key message on this particular slide is that beware of normal anatomy and variants, and remember thymus tissue has no mass effect and it doesn't compress airways and vessels, and it shrinks once the patient is sick and bounce back once patient recover. So this is case 2, 2 years old, presented with cough, dyspnea, and irritability. So this is a chest x-ray provided to you, frontal projection. What do you think is the likely diagnosis? So here are the options. Is this asthma, as patient is having cough and dyspnea? Or are we thinking of some pulmonary sling that is resulting into such symptoms? Or is this a foreign body, maybe the viral illness, or a big mass? Call for help. So let's see how our audience is thinking. Great. So 68% of the audience is thinking about the foreign body. That is the right answer. So I'm very much happy with the audience today. So excellent approach. So after every poll, I think there is some issue is happening with the presentation and it's being stuck. So let me change it. No, yes. Okay, so the right answer is foreign body. So what's going on in this particular X-ray? Did you notice that patient is rotated? Anybody noticed? So here the patient is rotated. That there is the spinous process is having the more distance on the left side. So patient is rotated on the left side. So that's why you can expect to see hyperlucency on the left lung. But beside that, there is gross asymmetry. So you need to look for that. So here you see there is smaller lung volume on right and left lung is bigger and more blacker, hasty black. And how about the vessels? All the vessels are very much smaller in caliber. So again, there is some mediastinal shift. So all these findings reflecting there is something that is lying, that is resulting into the air trapping. So we need to confirm with further views, especially the expiratory view. But unfortunately, here we are dealing with the children. So in pediatrics, it's very difficult because children are not going to follow you all the time. They are screaming and crying. They are not very much uncooperative. So in that particular scenario, what to do? So how are we going to prove that? So we need to confirm it on the lateral decubitus view. So what's happening in lateral decubitus view? Here, this is the right lateral decubitus view and this is left. So on right side, if you are going to see, this is the normal side where we are not going to see any foreign body. So there is passive recoil of the lung. So all the air is being going out when patient is lying down on the right side. Same is happening as we are expect to see on CT scan, the basilar atelectasis on axial sections when patient is lying down. So on the contrary, if you are going to see the left lateral decubitus, the affected side, so here you see the air is more like air is being trapped and continuously air is coming in, but it's not going to get out of the lung. So again, thank God we got this culprit. So this is the foreign body, and that was a gravel which patient has aspirated while playing in the front yard. So that is sitting into the left main bronchus. So that was the culprit. And sometime on left lateral decubitus view, the foreign body is visualized. But this doesn't happen most of the time because of the fact that most of the foreign bodies are radiolucent rather than radio opaque. Only 20% of the foreign bodies are radio opaque. So that's why it's very important to find them. Sometimes not necessarily on the X-ray, sometimes we need additional adjunct tools. So for the foreign body per se, I must say sometimes history is very much confusing, especially even the mother is not aware about the patient because the children are playing with their friends and mothers are not all the time they are supervising the child. So what happened? Patients have children have so much curious habits all the time. They are putting everything in their mouth and aspirate it. So it's very difficult sometimes that we are suspecting on some grounds that patient is having a failure to thrive and patient is having low-grade fever or often on cough, then we are going to think of some foreign body. Otherwise, sometimes history is also a mystery. So this is a very nice illustration I found while making this presentation from radiographics. So in this particular illustration, they beautifully have mentioned about this obstructive emphysema pattern, that is the Balwal phenomena we are going to expect. So there's air is going in, but air is not going to pass out. So that is being trapped and it will leading to the mass effect and sometimes the obstructive emphysema in distal airways. So this is the bowel valve mechanism. So the key message on this particular slide is that foreign body should not be neglected and urgent recognition is the key, and always check the asymmetry. So suspect the foreign body when the patient is unable to thrive and patient is having off and on shortness of breath. And remember, most of the time X-ray turns to be normal. So this is my case number 3. So here again, you have a set of images. So what is wrong with this premature neonate? Where is the abnormality? So let's activate the poll. Okay. So are you thinking that heart is affected? Maybe the pleura is the culprit? Or is it the esophagus? Okay. Or is it the lungs or bone? So majority, the 60%, 64%, oh, it's quickly changing. Okay, let's stop the poll. So 63% of the audience is thinking that lungs are affected. Yes, absolutely. I will give you half of the number because lung have the changes. But what is the major cause? So do you want to try another lung? I'm giving you time. Okay, so still the results are not so much satisfactory. So the key point on this particular case, this case is very much a super crazy case, I must say. It's a very dangerous case. So always, okay, good. So now many of you are thinking that heart is abnormal and 30% of the audience is thinking that esophagus. Oh, great. So big applause for those who have who have selected the esophagus. So esophagus is the right answer. So again, I'm sorry, I need to stop share and reshare. I'm really sorry for that, for this technical glitch. Okay. So esophagus is the right answer. So it's make it as your habit. Whenever you are dealing with any chest X-ray, always look for the tubes first. Before commenting on rest of the pathology, make it as a habit. Always look for the tubes, lines, and whether they are at appropriate position or not, or are you dealing with some complication related to them. So here, if you are going to focus this trachea, very nicely demonstrated trachea, but there is a tube that is an endotracheal tube, again seen parallel to the trachea. Rather, it's not inside the trachea. So if we are going to focus this oblique view, there is an anterior column trachea line anterior to this tube. So this is then esophageal intubation of the tube. Moreover, if you are going to focus the lung tissue, there is lung hypoplastic. Both lungs have less aeration because all the air is being going into the esophagus, and now there is ballooning of air into the stomach and the distal bowel. So these are the key findings on this particular case. And then lateral view was performed just to confirm the findings. So you see, this is the endotracheal tube that is impacted into the esophagus. There's a nice column of air, and there is massive ballooning of the distal esophagus, and then the stomach, and air is going into the distal bowel as well. So there is the inadvertent placement of the tube into the esophagus. So again, this is a catastrophic emergency, and you need to know this. You need to be very much aware about this condition and let your clinical colleagues know about this emergency situation. So this is a very nice important article I found while making this presentation. So you need, if you are interested, you can go and read it and Google it. So my key message on this particular case is time is money, and don't miss this esophageal intubation emergency, because it has a very catastrophic effects, and always make it as a habit before commenting on anything else. Make it as a habit to look for the lines and tubes and its related complications other than the pathology. And also a radiologist would be the first one to diagnose this. Okay, so here, this is my case number 4. This is a 13-month-old girl with fever, high-grade fever, and cough for 6 days. So there is acute history, and it's a young girl having high-grade fever. So where is the abnormality? Again, you need to look harder. Is it lung, or again pleural spaces, maybe the mediastinum, neck, or abdomen? Let's activate the poll. Okay. So great answer. So just keep on changing. Okay. I'm really happy to see that today we are having a new audience, very nice audience, and you people are knowing, mashallah. So majority thinks this is neck. You are absolutely right. Excellent approach. So let me reshare it. Stop share. Reshare. Okay, sorry for this confusion again. Okay, the correct answer is neck. So beauty of this case is that patient has presented with cough. Again, that is a very non-specific symptom, but something related to the chest. So we need to look for the chest as well. But again, sometimes the disease pattern is not lying within the chest, because airway, we are not expect to see within the lung itself. We have an upper airway, we have a lower airway as well. So we need to trace for the upper airway as well. In this, just like in this case, you see there is a high density, there's a soft tissue opacity seen within the retropharyngeal space, and that is causing widening and significant compression effect of the airway. So based on these findings, which are we have picked up on the lateral view, we just go for a dedicated X-ray neck AP lateral view. So again, on this particular X-ray, you see there is a very dense soft tissue opacity that is lying in the retropharyngeal space, and it is almost double up the space of the anterior-posterior diameter of these vertebra. So remember, this space should not be more than the anterior-posterior diameter of the vertebra. It's a rough estimate. It's a subjective finding. But here it is almost double, and it is causing significant compression of airways. So again, it's an emergency which should not be missed, though it's a corner of film image. So we further confirm this on the CT scan. So in sagittal CT scan, there is a long area of collection that is extending from the adenoid to the distally into the superior mediastinum. So this was confirmed case of the retropharyngeal abscess, which was incidentally picked on the chest X-ray. So take-home message on this particular case is, God, don't miss the corner of the film case. Always you need to look for other causes as well. Beside the lung, you are not supposed to look at the lung, but rest of the corner fields as well. Like you need to look for the soft tissues. You have to check for the upper abdomen, the neck tissues, and the bones, everything else. You just don't want to focus on the lung. So don't miss the classic review area abnormality, and always remember there must be some focus lying elsewhere. You need to dig out for that. Like you need to check for the ear, the nose, the paranasal sinuses, the infection lying somewhere else. And that can be a basic reason for that particular infection which is happening into the retropharyngeal space. And always be aware of this dangerous space, because via dangerous space, it can be extending up to the superior mediastinum. So it's an emergency which should never be missed, especially in from us. So this is our case number 5. And here we are dealing with a 3.5 years old patient presented with chest X-ray with acute shortness of breath. So what is the likely diagnosis? Are we dealing with solid pulmonary nodule? Is this pseudotumor? Or you people are thinking on the lines of bronchogenic cyst? Is this pneumonia or artifact? So it's keep on changing, very to and fro, to and fro. So many of you are thinking that's a pseudotumor. Okay, great, great. So I'm again happy. 56% of the audience is thinking on the right lines, in the right direction. So here we are dealing with pneumonia. So thank you so much. Let me stop share, reshare. Okay, so the right answer is pneumonia. So what kind of pneumonia it is? So it's a very different entity. As I just say, we are dealing in pediatrics, so don't expect anything normal in peds. So this is a round pneumonia, a very different kind of pneumonia that is only be seen in the pediatrics. So why? Because there is poor development of lateral collateralization. The collateral channels, the collateral ventilation is hampered, and it's immature for the time being. So that's why it limits the infection spread. So infection is not going to spread laterally into the other segments. So it is lying in just like an equine lesion. So don't consider it as MS, because it lacks some time air bronchogram. So always it's a very, very suspicious looking, like in this case. So don't confuse it with a mass. So that's a message from this X-ray. So again, this case was followed up, and on particular follow after empirical therapy, all has been managed. So it's completely normal on bone. So don't need to follow this up on the CT scan. Just a follow-up is important, but sometime even without follow-up, the patient is fine. You're not going to suppose for the X-ray as well. So this was a case of round pneumonia, and really happy you all, most of the audience has picked up right. Thank you so much. So the key message on this particular slide is this: children are not miniature adult, as we are dealing with a different entity, and it's again very don't consider and mimic a mass. So always be aware of this entity, and if you are dealing with this kind of appearance after 8 years of age, then you need to think something else rather than a round pneumonia, because after 8 years of age, or sometime in some literature it is saying 10 years after first decade, most of the collateralization has been fully developed, then you have a different kind of pneumonia pattern rather than a round pneumonia. So if you find any opacity after first decade, then think something else, not the round pneumonia. So this is my case number 6. So I'm going to show you a neonate, and it is presented with respiratory distress. And here the images, initial images are taken when the baby was born. And a couple of X-rays are being taken in next 2 days to the 2 weeks. So what's happening with this child? Let's see. Oh, mashallah, great, great, great. So it's keep on changing, very quickly changing. Okay. So 21% of the audience is thinking on the lines of CPAM. and 53% are thinking that it's congenital lobar overinflation. So great, again, audience wins. So I'm really happy. You people are, mashallah, very genius. So again, stop share, reshare. Okay. So in this particular case, what's going on is the patient born, baby was born. So you see higher density in the left upper lobe. So that was because of a retained fluid, fetal fluid in the left upper lobe. So later on, again, it's on the same day, but it was then replaced by some lucency, which is again happening in the left upper lobe. So why? Because the patient, as the baby was born initially, and when the patient cries, and then air is being indrawn, and that being fluid being replaced by the lymphatics, and air is again having in that particular region. So a lung is filled with the air later on, which is in a progressive manner. Initially it become lucent as in day 2 x-ray, and then become overlucent in a progressive manner. So sometime it has a variable presentation. So the right answer was the congenital lobar emphysema. So it has many variation. Initially, it was a solid looking. Later on, after the resorption by the lymphatics of this fluid, it becomes more lucent, become hyperlucent, and sometimes it has a very huge mass effect. So depend upon the case. So again, it has a very variable approach. It's not changing. Okay. So the right answer was congenital lobar emphysema. So nowadays, it no longer be called as emphysema rather than an overinflation, because of the fact on histopathology there was no emphysema was found. So it was a misnomer. So nowadays it is being called as congenital lobar overinflation. So key message on this particular case is this is always look for the location, because there are few entities in the radiology which have a particular predilection for lobes. So you need to look for those. So again, it has a left upper lobe predilection followed by right middle lobe and then the right upper lobe. So if you are going to see anything in the left upper lobe which is having the different phases and different variation in the course of the disease later in the serial x-rays, then you need to think for the congenital lobar emphysema. Okay, so this was common bronchopulmonary developmental pathway abnormality. Again, it has a ball valve phenomena, and it is associated with certain cardiac abnormalities. So need to look for that also, and also you need to go for an echocardiogram in order to confirm those. And again, another concept which I need to at this particular time, that is the variation in the course of the disease. Because in radiology there are lot many diseases, especially in peds, that have very different variation, because they are not, they are keep on changing with the passage of time. So all the time the disease is not on the same page. Like it's sometimes it has a full-blown stage, sometimes it's a burnt out stage. So you need to aware of all these things before commenting or before making a or framing up your diagnosis. So it's again very important about the course of the disease, like in this case. So this is my final case, a neonate that is admitted with difficulty in breathing and grunting, and it require intubation. So what is the pathology? What do you think it is? By looking at this funky kind of chest x-ray, are we dealing with pulmonary hypoplasia? Is this cardiomegaly? Or is it bowel obstruction, bony abnormality, or mediastinal mass? So 33% are thinking that it's pulmonary hypoplasia, and 9% are thinking on the lines of mediastinal mass, 4% are with the bowel obstruction, and majority again wins, that is 49% are thinking that it's a bony abnormality. So I'm again happy with that. Big applause for you. Okay, so this was no doubt a bony abnormality. So what is going on? Basically, always in the cases with the respiratory distress, you need to look for the cause. It's not necessary all the time you are getting something in the chest. So sometimes the bones plays an important role in the respiratory distress of the patient that can cause that particular symptom. So here you see the bell-shaped chest. Chest shape is very much funky, and it's a bell-shaped, narrow, and slender like ribs. Look at the ribs orientation. These are curved and slender. Again, the lungs are hypoplastic. And have you ever noticed this clavicle shape? Which shape is this? Handlebar clavicles. So this is a case of June syndrome. So you need to look for all these entities. This is a companion case of another child having a myotonia dystrophica. So this particular child at 1 week old, again you see there is an ETT tube that is seen that signifies that patient is in significant respiratory distress. And you see, don't forget to look for this normal looking thymus that is again very much transparent, and don't confuse it with a mass. And you see, look at the ribs, how the orientation of rib is that. So ribs are very much thin, very much slender. These are verticalized kind of ribs. Again, there is significant demineralization going on. So it's not always the lung that can lead to respiratory distress, but look at the bones as well. They should be in your review area and checklist. So coming to this case, this is the follow-up case of that particular child. Again, the same pathology. And on this case, you are expected to see the atelectasis as well. So again, this is a case of congenital muscular dystrophy. So key message uh, on this particular case is that always look for the bones and keep them in your checklist. And for that, you need an eagle eye and tough calls in the chest imaging. Know your anatomy, make your radiology. So always have a second look on the bones. So the final teaching points, I just emphasize on the fact that be knowledgeable about the normal variants, because these are very much challenging when dealing with the children, especially, and they are great mimicker of the pathology, and all the time you can confuse if you are not aware about those. And the subject grip is also very much important, and especially those entities which are only be seen in the peds. And you all need to check for the developmental changes that are being happening, that are being reflected on the imaging. So again, these things are very important. And you need to recognize the review areas, check your all the corners of image, use a very systematic approach. All this from today's talk. And under pediatric radiology, finally, I say always there is not a black and white answer. We can direct the clinician to some way, but not always all the time. So it's just like that. If I say find the face among the coffee beans, so maybe some of you pick up the one face, and if I show you the same image after a few months, and I say revisit this, then maybe few of them say there are two more faces. But if someone who is attending discrepancy meeting on daily basis, that he or she may be able to find three more ladybirds. So this is the problem with the radiology, which all we radiologists face. The more we see, more we get confused, and more we get eye-tuned. So pediatric radiology is different. And I just finished my presentation with a quote, a Japanese proverb, that is better than 1,000 days of diligent study is one day with a great teacher. Dedicated to all my teachers. I'm really respecting my all the teachers, and may God bless them. And I just these were the few thoughts, random collection of my thoughts, not a very organized lecture. And so I must say, you don't want to be fooled, and don't be scared with the pediatric radiology. And because you people are, mashallah, great audience today, as you are all, you have correctly picked up all the cases. And if you have still any doubt, you can ask your friend, your mentor, your buddy, your colleagues, but still you have confusion, you can email me at any time. Thank you so much for kind patience. I'm happy to take the questions.
Thank you so much, Dr. Maria. I would now kindly request our speakers to answer a few questions before we end the session. So the first question is there any role of angiography in congenital heart disease?
Yes, definitely. Angiography plays a very important role, and before the advent of multi-detector CT and MRI, initially the cardiologists were doing echocardiography and then the angiography, definitely. But it is more invasive, and you don't want the little ones to go through that invasive investigation. That is why the role of mm, cardiac CT and cardiac MRI have come into play, and most of the questions are being answered. So, like the cases which I have shown, at least the one with the large PDA did undergo angiography, not for diagnostic purposes, but for stenting of the patent ductus arteriosus, as the baby was not fit enough to have complete repair for tetralogy of Fallot. So definitely there is a role, and sometimes you're not able to answer. Like recently, I was not able. We did see a case where the question was, are there AV malformation in the periphery of the lungs, and possibly they were so small that we were not able to see them on CT, and definitely patient will undergo an angiography, definitely.
The second question states what congenital heart diseases can be easily picked on anomaly scans.
Normally, the way anomaly scans are being done is that mostly we look at the four-chamber view of the heart, and we would like to identify the interventricular septum and AST, but those kind of lesions may be missed. So remember, congenital heart disease is not very common, and you have to have a high suspicion to look for that. But dedicated echocardiography almost picks every congenital heart disease. So, like transposition of great vessels or total anomalous pulmonary venous return is normally picked up antenatal. Yeah, but if
The next question is directed to Dr. Maria, and it says, how effective is ultrasound as a modality for assessment of pulmonary pathologies? Any additional benefit over serial X-rays?
Yes, ultrasound have a very nice role, and apart from the X-ray, they give you additional benefit, specifically in cases of the when we are dealing with the pneumonia and its associated complications. So we can deal with whether it's a complicated pneumonia or it's a simple pneumonia to treat, and not only for the diagnostic but also the percutaneous aspiration we can also do from the ultrasound. And there are certain ultrasonographic findings or signs. There are particular signs which can we can see in many of the cases, like in pulmonary edema and in pleural effusion. There are so many different fancy signs. So again, the ultrasound is a very nice adjunct, can be used in particular with the chest X-ray. So we are also using it for all the patients who are coming to our department for that particular.
Thank you, Dr. Maria. The next question states, how to differentiate pulmonary interstitial emphysema from simple hyperinflation of bronchiolitis on portable X-rays.
pulmonary interstitial emphysema, and with what should normal emphysema?
Simple hyperinflation of
Bronchiolitis obliterans. Okay. So pulmonary interstitial emphysema is usually a complication of the barotrauma, basically the patients who are under the mechanical ventilation. So in that particular scenario, you are seeing a very nice sneaky kind of the lucencies along the airway bundle and the adjacent to the hilum and the bronchovascular bundles. So this is the particular lucencies. These are you expect to see on the chest X-ray. While in cases of the bronchiolitis obliterans, you're usually dealing with an air trapping kind of scenario. It's at the segmental level, not at the major and the perihilar level. It's basically at the segmental level, and distal airways are more affected. So most of the time on the merely on X-ray, these are not picked. You are only get to see the increased lung volumes, and there are some sort of COPD, chronic obstructive airway disease kind of appearance on the X-ray. Later on, you can confirm on the CT scan, HRCT chest, in which there may you find some air trapping. Again, the expiratory views are very much important. And if we are dealing with a child who is cooperative enough, who can expire on that particular CT scan, then you can see the good expiratory view. So in this case, you can confirm them. But if we are dealing with the neonate, again, it would be very difficult to confirm the air trapping in those particular scenarios. In this way, we can confirm. So pulmonary interstitial emphysema usually have a scenario based. It has an usually a barotrauma kind of complication rather than a simple emphysema.
The next question is from Anam, and she's asking many of the times we get stuck between equivocal findings between cardiac, pulmonary, and congenital abnormalities, and how should we report safely?
Sorry, can you repeat the question, please?
Ma'am, she's saying that many of the times we get stuck between equivocal findings between cardiac, pulmonary, and congenital abnormalities, and how should we report safely?
So, especially in small neonatal X-rays, you have to have, first of all, a very good history, and then you have to start very systematically, just like very nicely Dr. Maria has given you that approach